when it comes to my disclosure, I have nothing to disclose but participation in 2 European projects, and actually my presentation will be about one of them. What I'd like to tell you more today is the DIDACT project. It's a European project with aim to develop a longitudinal clinical reasoning curriculum, and also the trainer course. We have partners from several European countries. You have a list of those in the box, but also several associated partners. And we include many professions. We have, of course, physicians, but it's also very important for us to collaborate with nurses, with physiotherapists. We have psychologists in our project and computer scientists as well. This project is planned for 3 years, and we are just about to finish it, so I'm glad that I can show you the outcome. To develop a curriculum is quite a complex process. Maybe you know it from your own experience. You can easily get out of the right track. So for that, it's good to be guided by a framework. And maybe unsurprisingly, we have selected for that a 6-step approach by David Kern. The first step is problem identification and general needs assessment. What we in general like to address is the high incidence of medical errors. It's estimated that around 10 to 15% of cases in primary care, in emergency care, contain some errors. And what we hope is that through introducing more clinical reasoning into into curricula, we will lower this error rate. But before we really reach this stage, we need to make sure that there is enough clinical reasoning available that could be part of the curricula. And we wanted to estimate what is the current status. For that, we have organized a survey, a web survey, which was distributed by a mailing list of one of the biggest medical organizations worldwide, which is AMI. And we received more than 300 responses from more than 70 countries. And it became clear that such clinical reasoning curriculum were present only in 1/3 of respondents' medical schools. And the demand was obvious. More than 85% of respondents thought it's needed. We also wanted to know how is the situation in terms of training of faculty in clinical reasoning teaching skills. And again, not much happening, just present in 1/3 of the responding institutions, and the need is enormous. So we were confident after first step that our work is needed. Then it's also important to investigate locally what is the demand in the institutions that are directly affected by the curriculum we developed. For that, we have organized close to 30 semi-structured interviews with experts, with teachers, students, to realize what is the hindrance, what are the barriers in introducing such curriculum. And in most cases, or very frequently, the reason that was given was time limitations. Teachers do not have time to teach. They do not have time for faculty development to become better in teaching clinical reasoning. And we had it already in the panel discussion. Curricula are full. There is difficult to find place for even such important topics as clinical reasoning. There is a culture barrier to be open about errors, to discuss it with students. There's also a prevalent disbelief in effectiveness of explicit clinical reasoning teaching. Many teachers say, okay, yeah, we never had clinical reasoning in our curriculum, but we are experts in clinical reasoning, so it should come with age. It's just a matter of experience. It's also for some surprising that there might be other methods of assessing clinical reasoning than multiple choice questions. People, if they need to learn something new, like they need to introduce new content to the curriculum, often ask, okay, what will I get for that? They need some either monetary incentives or at least recognition from the top. Some complain about the technical infrastructure, no good tools to support, or maybe they have what they have is not necessarily what they like. And there is also a lot of discussion. Yeah, what do we actually mean by concept reasoning? Is it clinical reasoning? Is it something that, for instance, nurses are doing, or is it just for physicians? Knowing those barriers, we came back to the literature. We have analyzed also national learning catalogs. And in a series of group consensus meetings, we have developed a set of learning objectives, which were grouped in 11 categories. You can see those 11 categories here in the slide with colorful dots next to it. And then it would be too detailed to present you here all the learning objectives, so just a sample of 3 of them. So for instance, you see a brown dot which belongs to the collaboration theme or category. And the learning objective said that the student will be able to demonstrate an understanding of similarities and differences in clinical reasoning across health professions. Next, it's important to decide on the educational strategies. What we wanted definitely to do is to make the curriculum learner-centered. We mean by that incorporation of many forms of active learning, like small group discussions, but also individual activities that still require creation of something, like writing blog entries. Then we like to give the student the autonomy, but also responsibility of selecting parts of the curriculum that they are most inspired by, they find most motivating. So we move ourselves more from the sage on the stage to the position of a guide on the side, to see how we could help them then to enforce what they have to learn. We plan the curriculum to be blended learning, so to have a meaningful mixture of online and offline activities, and also synchronous and asynchronous phases. And we believe in case-based learning. We want the students to learn based on authentic examples Some of them can be short patient vignettes, but we also very much support virtual patients. We decided to divide the curriculum into small learning units that could be repeated all over again across several levels with deepened difficulty levels. We also think it's a good method to let the students set goals, receive feedback, and then work on improvement of particular skills that could be included in clinical reasoning. We believe in deliberate practice. So this is probably the most important slide because it shows an overview of how the curriculum looked like. I do not expect you to read it in detail. It's too small in the slide. You have here a QR code you might wish to scan to have detailed picture on your mobile devices. What is important for me to show you, to explain to you, is that those boxes here, each of them that contains text, denotes a separate learning unit. Learning units are divided in columns. Those columns correspond to a different difficulty level. So starting from novice level to intermediate up to advanced level. The column on the right-hand side is or are train the trainer learning units. So those that are for faculty development. You see also rows, and next to them are colorful dots. These are the themes, those categories I have shown you a few slides ago. So I will now zoom in to let you see a sample of titles of learning units we have developed. They are usually a few hours long, divided in 2-3 phases. We often follow the flipped classroom methodology, where students do something individually at home using online content, and then they deepened the understanding in small group activities guided by a teacher. But there are different study design actually implemented. Everything is open, free, available. If you click on the names of those learning units, a window will appear where you can select either to access the curriculum as a student or to see instructions for this particular learning unit from the perspective of the course facilitator. And you can either create a new account and log in that way, or you can also use your university account. We are using the system EduGain, and actually really many European universities are part of that. So if you are from Warsaw, for instance, or from Poznań, you are part of EduGain as well, so you can log in to those modules using your existing account. We have implemented the learning units as courses in the learning management system Moodle. So each of the learning units is a separate course. You can enroll in as many as you'd like to. And then once you are enrolled, you see instructions that can be either followed in self-directed mode or in a limited or slightly modified version as part of a guided implementation. On the right-hand side, you see instructions for facilitators. And probably the most important part of this part for facilitators is an Excel sheet with very detailed instructions what should be done in the individual time slots or parts of the learning unit. So a division into 10-15 minutes, what question can be asked, sometimes some additional links to sample solutions can be, or deepened videos can be found there as well. We have evaluated 5 student and 5 train-the-trainer learning units in a series of 17 pilot evaluations conducted in 6 countries. Close to 200 students participated in that and approximately 100 teachers. We consistently use in evaluation a tool developed by David Cook and Rachel Ellaway called ETLM. It contains close to 20 items. No time to present you all the questions we have asked, but we were very pleased to see that on a scale, on a 7-point Likert scale, where 1 is definitely disagree, 7 definitely agree. Students and teachers, when asked whether our learning modules improve their clinical reasoning skills or respectively clinical reasoning teaching skills, we got an average of around 5.8, 5.9 points. So that was pretty much encouraging. We were also prized for a good blend of online and face-to-face elements. But when it came to the general quality of the learning units, it was clear that there are also some points for improvement. And we investigated what it could be by analyzing qualitatively answers to open-ended questions. And many of our respondents complain about difficult navigation in Moodle. It's probably not the first study or the first project where people are not entirely satisfied with how intuitive Moodle is. We use Moodle at Jagiellonian University as well. We call it Pegas. And the problem is, if you have an open or free to use system, we also are pretty much based on open source systems. We have sometimes fit too much content in the time that was given. So the course is from time to time too intensive. But luckily, there were several positive points that were also mentioned. And in particular, those small interactive group sessions is something that is valued in the curriculum. So what we have planned was also recognized. So now coming to the conclusions. We have managed to put a complete clinical reasoning curriculum free available online, and it's for you, so you can use it anytime. It was positively evaluated, but what I'd like you also to do is to think maybe beyond the DIDACT project, which is just an example of a hopefully useful resource for you. Think of the barriers I have presented to you in the beginning and consider whether what we have developed could in any way help you to introduce clinical reasoning at your faculties, at your universities, because this is you who could change what we still observe as not enough clinical reasoning teaching and assessment in health professions education. Of course, there is still a long way to go. We need to see how to evaluate the outcomes of this project also beyond the satisfaction level. We'd like to introduce more of our learning units in the curriculum. But this is still a work in progress, and I'm looking forward to the discussion with you in terms of what is for you difficult in implementing clinical reasoning at your universities. And beyond the panel discussion, I think we would be also happy with Steve, with Inga, to talk with you on that, maybe in the coffee break or after the last session. And well, that's it. Thank you.
Thank you very much, Andrzej. The question is very important, and I hope very easy to answer. How long those resources will be available and how they will be maintained? So you're planning on updating cases or not?
Okay. Thank you for this question. Actually, sustainability of the project is something we discussed just 2 days ago. And so the good news is we are not planning to restrict access to those resources anyway. So by law, they are available for at least 5 years. But we know from previous projects that the cost to just leave the content online is minimal, so it's likely it will stay even longer. The more tricky question to answer is what about the maintenance? And well, it's the funding is over. It might be that we get more funding that will have this particular goal of maintaining, of extending the collection. If not, we are open to
well, you can as well participate
to collaborate with other if you are enthusiastic about enough about clinical reasoning. We could maybe together share our limited time resources and extend what is needed to be extended.
Now, one more question, single sentence answer. Okay? If someone wants to start with it, use your resources, where is the first place to go to?
DID.
So your web page.
Our web page.
It's in the title, which means it's on the web. I mean, on the conference, in the title of the presentation, which means it's available online. Thank you very much.